Deficiencies can come from a number of causes. They can come from a large enough tumor that squishes the other normal cells. It can come from radiation or surgery to the area. And it can come from other types of traumatic brain injury and various types of strokes, specific types of strokes. So those types of brain injury are known to also predispose to pituitary damage. You could potentially also have an autoimmune effect on the pituitary that would cause a deficiency, or tumors that aren't in the pituitary but that affect it, or where the treatment affects it. Right. So there's some genetic predispositions also. But the most common causes of deficiencies would be either a tumor or surgery or radiation for that, or certainly many more people have concussion, say, or brain injury, or a type of brain injury can produce it. They don't always.
Hi, welcome to the next edition of Brain Case Live. I have a wonderful guest with me today. Her name is Tamara Wexler, and she's a doctor here in Virginia, in the Northern Virginia area, and she's a neuroendocrinologist. And I've had an opportunity to work with her before because one of my clients who had suffered a brain injury had some other things going on that nobody could figure out. Well, Dr. Wexler figured it out, and it happened to be a dysfunction in his pituitary gland, which was related to the brain injury. And this was something that was new to me and just a fascinating aspect of helping people with brain injury that I had not had experience with before. Really opened my eyes to making sure that this issue is being thought about when it comes to taking care of treating brain injury survivors. So, Dr. Wexler, welcome to Brain Case Live, and I'd appreciate it if you could just introduce yourself, tell us who you are, what your background is, and that sort of thing.
Sure. Thank you so much for the opportunity. It's always a pleasure to get to speak with you, and particularly to have the opportunity to raise awareness of this area, since it can, I hope, make a difference in a number of people's lives. As you mentioned, I'm a neuroendocrinologist. I started out in research as well as medical school. My PhD is in neuroscience, and that was very basic research. I went on to do much more clinical research, which is what I continue to do. I spend my time divided between research and patient care, and as well as wear a totally different hat and do some public health and biotech consulting. But my main focus has been learning more about the pituitary gland hormones. I'll discuss what that means, maybe, okay. And how they really can affect public health. The pituitary hormones. There's a set of hormones the pituitary gland manages: stress hormone, thyroid hormone, sex hormone. So it also has to do with fertility and growth hormone. And when I started my career in this area, and I've always, medically speaking, been interested in that area, I was focused on excess of these hormones, things that can happen from tumors that arise in the pituitary gland. Really loved that work. But admit that it felt like it was affecting sort of a smaller population, not a big public health problem the way that, say, diabetes is or heart disease is. And learned later, or I guess became more aware myself, of the role that pituitary hormones and potential deficiencies can have after brain injuries, which is, really opens up for me the public health impact of pituitary hormones. So I'm really glad to get to speak about it.
Well, great. Well, it's great to have you. And what I thought we would do, we've got people who watch this podcast range anywhere from people who are just curious and the general public, non-medical people, people who have either suffered a brain injury or know someone who has, perhaps a parent of a youngster who's had a head injury playing football or soccer. We do have lawyers that watch the podcast as well. So that's your audience. And I thought what we would start with is just give us a little bit of an anatomy lesson. What is the pituitary gland and where is it? And we'll just kind of start with that very basic conversation.
No, great. Always best, I think, to start from the basics. I don't have my own model near me here, but
Yeah, I've
I'll
got
I'll
one.
demonstrate as best I can. Oh, that's great. Okay, so
Oh,
maybe
let me get my.
well,
So I have the
wow.
brain. I have the brain model here, and I believe where you're going to tell me to look
Well,
is at the base of the brain, right?
yeah, actually, and I don't even see it there, although I see the optic chiasm. That's the place where the optical nerves cross. It looks like an X. If you
Right
put
here.
it back in the skull base, yeah, so it hangs from there. Um, it's okay. It'd be at the intersection of my fingers, essentially. So if you put a finger at the top of your nose, one at your temples, it's around there. It's up behind the nose.
So
Uh,
pretty much behind the bridge of your nose. Okay.
Yep, yep, but well, and back under a little bit at the base of the brain, and it hangs. It's a gland. It's not that big. Um, it hangs from a stalk, and in that stalk run the nerves and the vessels, and it sits in what's called a sella. If that ever shows up on, radiology reads or something, which means saddle. So it sits in this bony saddle and hangs from a stalk.
Wow.
Um, yeah,
And it's about the size of a pea.
yeah, exactly.
I've heard. Okay. So so now that we know where it is, could you tell us a little bit about what it does? What is
Yes.
in a normal functioning pituitary gland? What does it do?
Yeah, this is actually what drew me to neuroendocrinology. It manages these beautiful feedback loops that help keep different hormones in balance throughout the body. It acts a little bit like the thermostat in your house. So let's take, for example, one of the hormones it manages, the thyroid gland. So the thyroid gland sits at the base of your throat. It makes thyroid hormone. Thyroid stimulating hormone, TSH, is made by the pituitary gland. And in fact, it receives the signal from above, from the hypothalamus also, focusing on the pituitary, but they really all work together. So
Hmm.
I'm definitely leaving out an important player here.
Sure.
So TSH, thyroid stimulating hormone, stimulates the thyroid gland to make thyroid hormone. If your thyroid gland isn't able to make enough thyroid hormone, the pituitary knows that, and it puts out a higher signal. So the same way, if your house is too cold, you'll get more of a signal to put out heat if you have your thermostat set to a good temperature. And similarly, if the thyroid gland was putting out way too much thyroid hormone, the pituitary would dial down the TSH, the stimulating
Got
hormone,
it.
and it works that way for most of the hormones it manages.
Okay. So now that we have these basic understandings of the pituitary gland and what it does, how it works, where it's located, uh, what are some causes of dysfunction in the pituitary gland? What can make it not work the way it's supposed to work?
Yeah, you can. It's all of the hormones act kind of like a Goldilocks hormones. Too much is bad, and too little is bad. You want just the right amount. So things that can put out too much are largely tumors, right? I don't mean cancerous tumors here, but too many cells that produce the stimulating hormones. Deficiencies can come from a number of causes. They can come from a large enough tumor that squishes the other normal cells. It can come from radiation or surgery to the area. And it can come from other types of traumatic brain injury and various types of strokes, specific types of strokes. So those types of brain injury are known to also predispose to pituitary damage. You could potentially also have an autoimmune effect on the
Hmm.
pituitary that would cause a deficiency, or tumors that aren't in the pituitary but that affect it, or where the treatment affects it.
Right.
So there's some genetic predispositions also, but the most common causes of deficiencies would be either a tumor or surgery or radiation for that, or certainly many more people have concussion, say, or brain injury, or a type of brain injury can produce it. They don't always.
Okay, so that's a good lead in to what does all of this have to do with brain injury?
Yeah.
And can you just tell us at a very basic level what the connection is between this little gland that's not part of the brain, I'm kind of gathering, and a concussion. So what's the connection there? How do we explain that?
Yeah, I mean, it is part of the brain. It hangs outside the blood-brain barrier, um, but it's a gland that sits that sits sort of underneath the what you would think of as the cortex or the brain. Um, and the connection to brain injury is well, I can answer that either from a um, pathophysiologic way or symptoms. So I'll say we know that traumatic brain injury and some other types of brain injury cause a higher rate of pituitary hormone deficiencies than you would see in the general population. So it's much more common in people who have had an injury than in someone who hasn't had a brain injury. That's not to say, again, that everybody who's had a brain injury develops a pituitary deficiency, but in the one study done in a healthy adult population, it's less than 0.04% prevalence or something. And if you look at the studies pretty carefully in patients who have persistent symptoms at, say, a year, it's about 25%. You find if you're applying clinical judgment to whom to test, you'll
Right.
find a pituitary deficiency. So one, it's more common. Two, the symptoms from pituitary hormone deficiencies can really impact people's lives, and they do overlap to a quite a large extent with symptoms you can have from a brain injury for other reasons. The difference here is that if symptoms are due to a hormone deficiency, replacing that hormone should reverse the symptoms.
Mm.
So it's the opportunity to really reverse or significantly ameliorate some of these symptoms that can dramatically change people's lives.
So what are these symptoms? So let's say we have a parent who has a youngster who's had a concussion and some time has gone by. Uh, what sort of symptoms should they be looking for to raise this as a possible explanation?
Yeah, and the people who have symptoms that can be from pituitary deficiencies, that pool is much larger than those where you'll find pituitary deficiencies, but it is really important to be aware because of, again, this possibility of making a real difference by simply replacing the deficient hormone. It's a little different, you said, for parents. It's a little different in children and adolescents and adults. Those are kind of different ways of that symptoms might appear. In children, you may see a difference in behavior or school performance, for example, as well as those that you can see throughout the lifespan will include physical changes. These may be a little bit harder to pick up. It can be harder to stamina is decreased, energy is decreased, fatigue is higher, for example. It depends on which hormone deficiency we're talking about here. So I'm trying to think of kind of just generalizing.
Mm-hmm.
Some of the things that I tend to think about more because I feel like it's harder to find other ways to influence them can be some of the cognitive or emotional changes. So there can be increased irritability, anxiety or depression. The cognitive changes include changes to processing speed and what we term executive function. So multitasking, word finding, short-term memory, focus, concentration, productivity. So those can be down for all sorts of reasons, but they can also be down because of a hormone deficiency. The physical changes, I a little bit skimmed over that, but it can be harder to gain weight or lose weight depending on the hormone deficiency. It can be harder to build muscle. These aren't symptoms, but if you looked at, say, the bones, there would be a difference there for some of the hormone deficiencies, and it can be subtle or dramatic.
So let's just take a typical concussion patient. They've had a concussion. Some time has gone by. They're having some of these symptoms. How I guess diligent is the right word, are your physicians out there in everyday life at thinking about and considering this possibility of pituitary deficiency or dysfunction when they are treating a concussion patient? Is this a problem where it's not diagnosed or undiagnosed?
Yeah, it's definitely underdiagnosed. I think that patients are certainly aware of the changes. I didn't even mention quality of life, which sounds vague, but in fact is a particular
Right.
area that can be affected. And they're aware of the changes, and their physicians certainly are often aware of the changes. I think the real issue is that even though there is a lot of information in the literature describing people who are symptomatic or have other characteristics after a brain injury and the pituitary hormone deficiencies, and sort of that this is a known entity, the awareness is not high. So that's the real issue. I mean, there's finally more awareness about what concussions can do, but the role of hormones, that remains significantly underappreciated. So this is really an area where awareness and education can make a huge difference. And why I'm so glad to be speaking about it. You know, you can have physicians who see patients with concussions, and certainly the awareness there is higher than in general physician population. Um, and their clinical judgment can be really helpful in getting patients to see a neuroendocrinologist or an endocrinologist specializing in these hormones. Oftentimes, what is described is that the patients just aren't getting better the way they should be, right? The way it would be
Mhm.
expected.
Right.
And we're talking now in the months to a year or more out from the injury, not in the first few months.
So when is um, the normal or appropriate time to look into this as a possibility? Because I know, and I'm sure many people watching this video know that you go to the doctor, you have a complaint, and so they do like the least expensive, least invasive, what have you, uh, treatment for it. And it may just be waiting.
Yep.
And then maybe if it's an orthopedic injury, maybe there's physical therapy. And then if there's not a resolution, maybe there's an MRI, that sort of thing. And it takes a while to get to the thing that finally finds what's going on. Is that how it is with this? And what is the time?
Yeah, you touch on two areas. One, this is an area, in fact, many neuroendocrine issues, but certainly this one where patients or their families, unfortunately, really have to frequently be their own advocates at a time when their resources are maybe at their lowest or their most vulnerable. They really sometimes need to be the one saying, I know something's wrong. Please, can you consider testing this? Would you like to read more about, or, let me offer you something? Because
Right.
it's not that their doctors aren't trying. Again, there is just a real lack of awareness about this or attention paid to the potential role of hormone deficiencies in recovery or in lack thereof after traumatic brain injuries, say here, because that's where there's the most information in the literature. Um, the time period, I'm going to term it sort of acute and chronic, but that's not actually well defined. So in the first few weeks or even like 3 months after an injury, there may be changes, but with a few exceptions, it's not thought to be appropriate to test or replace them because the body's just changing. It's maybe functional, maybe it's focusing its energies elsewhere. It's always appropriate to think about changes that can come from a posterior pituitary hormone called arginine vasopressin, can lead to swings in sodium. That's an acute and often transient issue. I'm focusing on the anterior pituitary cortisol, thyroid, sex hormone, growth hormone, because those tend to be where the chronic issues are. Cortisol is, again, always appropriate to test. But interestingly, a deficiency in the pituitary hormone or hypothalamic hormone that allows you to produce cortisol when you need it, if it occurs in the acute period, doesn't even seem to predict chronic deficiency. So you'd have to retest. So with the important caveat that I'm not ignoring the acute period, and there are certain things that it's worthwhile thinking about if appropriate. Focusing at least 3 months out is most appropriate for the anterior pituitary hormones on a chronic basis. The information we have shows that after 3 months, you can have deficiencies, and they can develop over time. There are really interesting experiments looking at children and adolescents and at adults that look at the same patients at 3 months, 6 or 9 months, and 12 months after an injury, after a traumatic brain injury. And in some patients, they don't have a deficiency at 3 months, but it's there at 12 months.
Hmm.
In other patients, they have one at 3 months, but it's recovered by 12 months. So, you can get snapshots, but the picture can also change over time. So other than cortisol and maybe the hormones that relate to sodium levels, it's most appropriate to test after 3 months. And for growth hormone, even more than that, after 6 or 12, even 12 months, because we know that can recover. Growth hormone is the most common deficiency found at or after 12 months after a traumatic brain injury.
Okay, so let's talk about the growth hormone deficiency issue when you suspect that as a possibility with a traumatic brain injury concussion survivor. What do you do as a neuroendocrinologist to look into that issue to see if it's there? How do you test for this? What do you do?
So patient comes in, let's say for the sake of argument, it's been at least a year since an injury. They've had these persistent symptoms, and then their physiatrist, neurologist, another physical therapist said, maybe you should get tested for a hormone deficiency because you're just not improving the way I would think you would be at this stage. So they come in to see a neuroendocrinologist. You don't just start off with testing for growth hormone deficiency. It's important to first test for a cortisol deficiency. And it's not the cortisol itself; it's the stimulating hormone from the pituitary, but that axis is a problem. Okay. So that's the first one you always have to test for. Then you can thyroid hormone is the next important one to replace. Then sex hormones, then growth hormone. You can do a sort of a single test for the first three axes, the cortisol, thyroid, and sex hormones, and see if there's an indication that they're deficient or normal. And then you go on to test for growth hormone deficiency. I can say specifically how you test for growth hormone deficiency if that's of interest.
Sure, yeah. So let's assume you get to that point and you want to test to see if there's growth hormone deficiency. How is that done?
I think this is another reason why there is some under the diagnosis of it. The biggest problem is lack of awareness, but there are two ways in which you can diagnose growth hormone deficiency. One is that a marker, a hormone made in the liver in response to growth hormone, IGF-1, is definitively low, and all the other hormonal lines are low also. You have adrenal insufficiency. That's the inability to mount a cortisol response when you need it. You have hypothyroidism, low thyroid hormone, because you're not making the signals from the pituitary hypothalamus. You have what's called hypogonadism. You're, again, because of central signals, you not putting enough estrogen or testosterone. Those are all present, and the IGF-1 is low. That's enough to diagnose growth hormone deficiency. In the absence of that, though, a low IGF-1 is not sufficient to diagnose it. And conversely, a normal IGF-1, doesn't mean you don't have growth hormone deficiency. And that's one of the misconceptions in this area, because 20 years ago it was thought that you just screen with an IGF-1, and if it's normal, you're done. That is, in fact, not the case. There is evidence, and there's studies that people who have normal IGF-1 levels fail what is thought to be more definitive testing for growth hormone deficiency. That more definitive testing is called provocative testing. You're basically trying to provoke the pituitary to make growth hormone and seeing if it can.
Right. So if you get to the point where you've concluded that there's a growth hormone deficiency, for example, from a TBI or from any other cause, what's the treatment for that? What's the next step?
Yeah, unless there's a reason not to give growth hormone, it's then replacing it, the same as it would be with any of the other hormones. Growth hormone is replaced by either a nightly injection or a weekly injection. The subcutaneous, for example, nightly injections, I have done sham injections on myself, and I will say, and patients have said, that you don't feel them. So I'm not talking about like a big needle or a vaccine needle or anything, but small needles, nightly or weekly injections.
Right. So if someone wants to reach out to you or investigate this issue, how do they get in touch with you? What's the right protocol, I guess, to reach out?
Well, their physician can do it, or they can do it themselves directly. I usually get emails from patients, or sometimes I have a website, neuroendocrinologist.com, that has information about this, and patients can contact me this way. And there are also groups like concussion groups, Concussion Legacy Foundation, Concussion Alliance, that can reach out to doctors who might be in your area also.
And do you do telemedicine visits, or are these, do they, I know you're located, I believe, in the Arlington or Falls Church area of Virginia. Do you see patients in person a lot, or are you more telemedicine? How does that work?
I used to only see patients in person. I believe I am on record somewhere saying that I don't think telemedicine is real medicine. This is years ago. And then the pandemic hit, and I started seeing patients by telemedicine in a number of different states. It can only be where I have a license, but I'm a professor, a clinical professor at NYU. So I have a New York license, and I have a lot of patients up in New York, Virginia, DC. I actually got a North Carolina license because I had a few patients there, and I didn't want them having to drive into Virginia after I'll say the rules during the pandemic changed, so you could speak to patients in more states. But when it changed back, I didn't want them to have to drive in, because I did my training at Mass General. I have a Massachusetts license, so I could theoretically talk to patients who are physically in any of those areas, but not elsewhere.
All right. Well, this is a really interesting topic. I know a lot of the terms that you threw out today are they're over a lot of people's head, and it can be a complicated subject, but it's just such an interesting area of brain injury medicine to me, someone who represents people who are suffering from the injury and are involved in a case over it. It's just something that I find to be very interesting, and the beauty of it is if it's there, it can be addressed with treatment. It's just a matter of making sure that the patient is getting to someone like yourself who can properly diagnose this and knows what to do if it's there. So
I can. If I'm
go ahead.
I interrupt when I get excited. If I'm making it sound too complicated, I'm not doing my job. So just to say that these are the stress hormone, the thyroid hormone, the sex hormone, the growth hormone are important in how you feel, and the symptoms of those can have pretty lasting impacts on quality of life, on productivity, and overlap with brain injury symptoms. And you can test for them, and if they're deficient, you can replace them. I'm always pretty careful to tell patients that, even if you have a deficiency, you don't know if that's what the symptoms are from. But if 50% of your change in focus, concentration, sense of well-being are from a deficiency, you should be able to reverse it 50% of the way.
Right. Yeah, which is in a lot of cases that I'm dealing with, we may not have a neuroendocrine issue, or there may not be a deficiency, but they still have some cognitive issues going on. And it can be just a chronic, permanent, lifelong problem that really does affect quality of life. So if this dysfunction is present and can be detected and addressed, that's just a wonderful thing for these folks. So thank you for what you do, and it's such an interesting topic. I know that people will find this very interesting. And you mentioned your website. Could you repeat that again?
Yes, and I'm also searchable through the NYU site website, or I'm adjunct at Penn, so through that site. But otherwise, it's neuroendocrineassociates.com. But again, you can just search for my name and NYU, and it should also pop up. It's just a different email.
Well, thank you so much for your time, Dr. Wexler. We've been talking with Tamara Wexler, who is a neuroendocrinologist, who's done a great job of explaining to us some complicated topics relating to brain injury, as well as some other issues. So thanks a lot for your time, and that'll do it for this edition of Brain Case Live.